Our speaker tonight is Dr. Vishaka Thakkar. Dr. Thakkar is residency trained in cornea, contact lenses, and refractive surgery. She is the owner of Vaughan Family Vision Care, a specialty contact lens practice where she primarily sees patients with corneal and ocular surface disease. She previously held the role of Director of the Contact Lens Service at the Cleveland Clinic in Cleveland, Ohio, and has spoken on scleral lenses and myopia control throughout Canada and the US. She is a fellow of the American Academy of Optometry and the Scleral Lens Society. She currently sits on the board for the contact lens section of the CAO, on the RCCO Contact Lens Working Group, and is a principal organizer for the CCLA conference. She has been a contributing editor and has written numerous articles for the Canadian and American journals. Welcome, Dr. Thakkar.
Thank you very much, Cheryl, and thank you to the OAO for having me. It has been a very busy week for all of you, and I want to take this opportunity to extend my thanks for everyone who has put together job action, everything that you've done for us throughout the pandemic. I truly appreciate it. One more thanks I have to you guys. Here we go. There we go. I kind of feel like this lately. I mean, I think so much has happened lately between opening our practices, closing our practices, job action, pandemic. I feel like I have a ton of apples in my mouth and I don't know what to do with them. And I know everybody on here probably feels the same. So I appreciate your time this evening for this particular talk. These are my disclosures, past and present. And just to kind of give you a background in terms of why I decided to do myopia control complications and challenges as part of this lecture. I really felt like I was originally going to do scleral lenses as part of the symposium. And I thought to myself, you know, myopia control there's a huge demand of knowledge that is going on in this country and worldwide. And we really need to learn more about it. And the fact is that right now, post-COVID, we are not allowed to do new fits, right? So why don't we talk about how to manage the challenges and the complications associated with them? So to get started, let's give, I just want to give some demographic information about myopia in Canada. It is considered an epidemic. It is potentially sight-threatening as we go into higher powers. More than 1 in 6 children between the ages of 6 and 13 have myopia. According to Lyndon Jones's group, prevalence increases with age. So with myopia affecting 6% in the 6 to 8 age category and 29% in the 11 to 13 category. Surprisingly, high-income North Americans are predicted to be 58.4% myopic. The global concerns are even higher. I mean, we've all heard this statistic a million times. 50% of the worldwide population is going to be myopic by 2050. East Asia is 65.3%, and urban communities are 80%. This last statistic, when I saw it, I was actually shocked. Almost 100% of Chinese students are myopic, or university students. Why should we be concerned? Well, I mean, we all know this, right? And I think the reason that I put this slide up for you is because my greatest issue when it comes to talking to patients about myopia, I don't want to scare them. I don't want them to feel like this is potentially something that's going to happen to every myopic child. But I feel like with parents, we really need to arm them. We need to arm them with the knowledge of what potentially can happen if myopia gets too high. I love this slide. So I saw this slide when I was in, or this picture rather, when I was in the States. And it's kind of shocking, right? Because people do put phones in babies' hands. And myopia we've known for a long time that myopia has been genetic based. You know, there are 200 loci mapped. With more than one parent with myopia, we know the risk is even higher. High myopia even increases that risk. But I think in today's time, and it's been really perpetuated during the pandemic, is the amount of near work and technology time that there is. I mean, we see 4-year-olds with iPads who navigate through it like you would never believe. So to see a phone in a baby's hand is not normal, but not completely abnormal either. We have to ask our patients, really what are the environmental influences in their life? How much near work are their children doing? Are they doing outdoor activities? I mean, when I was a kid, I was outside all the time. I mean, the only thing I did inside was homework and maybe watch TV on the 2 channels that I had back then. Now, kids don't want to go outside. They fight with you. They want their technology. Studies have shown, and as we all know, sunlight is a major contributing factor to the reduction of myopia progression. In fact, violet light itself has been a contributing factor. We have thought in the past that it was vitamin D or UV that potentially could slow down myopia, but they're finding that it's not really that, and it's still open as to what component of sunlight is attributing to slowing down myopia. Lighting is important, so are people outside or inside? Geography, are we in the northern hemisphere, the southern hemisphere? Is this a child in a rural population or an urban population? It makes a big difference in the influence of myopia. And of course, there's socioeconomic status as well. When it comes to risk factors, we really need to look at what are the higher risk factors when we're clinically seeing our patients. So red flags should definitely go off if both parents are myopic, if one parent is highly myopic, if they have already a sibling with high myopia, if there is a history of retinal detachment in a relative, so it could be a cousin, it could be an aunt, or if the child is Asian. So if you put all of those factors together, we significantly increase the risk of developing myopia in our patients. I did want to go over rapid refractive change with you as well, because I think these are certain clinical details that we need to be able to identify. Even if the patient is hyperopic and they have at least a plus 0.75 change, that is a red flag to telling the parents that there is a good chance they may progress into myopia. Okay, this often can happen up to 2 years prior to myopia onset, but it usually happens between the ages of 6 and 12. I mean, as many of you have, I have seen it as early as 4 or 5 years old, and in rare cases even younger. One thing we have to pay attention to is axial length elongation. I mean, that's nothing new. And I really invite any of you who are truly interested in myopia progression treatment, try to figure out even an inexpensive way of having an A scan like the DGH ScanMate to measure these types of things. Because what you will find is that before the onset of myopia, axial length accelerates, and then there can be kind of pauses and accelerations, just like you can actually see with their refractive error. I do actually have an A scan in my office. Some of you have IOL masters. IOL master is always going to be more accurate, but it's pricier, right? Even if you're getting a used one. The ScanMate that I have, it's less expensive. Unfortunately, I got it just before, just at the end of 2019. So the cases that I share with you today, I don't have axial length measurements, but it's something that will really help in your clinical practice. I wanted to show you this slide. I'm not going to go over it, but Longis-Michaud, this was actually in Contact Lens Spectrum in 2016. If you haven't seen this flowchart, it gives us a good sense of how to proceed with myopia control treatment. What age, if it's this age, what should we do? This level of myopia, what should we do, etc. So for those of you just starting or, basically in your early stages of myopia control, I love this chart. This is actually good for all of us. Okay, so my first polling question. I want to get a sense of the audience. So I want to know what you guys are doing to help control myopia. So number one, or A, I should say, do you use Atropine 0.01%? Do you use soft multifocals, Ortho-K, progressive or myopia controlled design glasses, Or do you use 2 or more of the above modalities? So we'll give you a few seconds to answer. And you may use all of these. I wanted to limit the number of questions that I was asking. Okay, so, I mean, this doesn't surprise me at all. So 41% use 2 or more of the above modalities, which is great. I think the big turning point in treating myopia is when soft multifocals really became more popular because, in this group, we only have 4% using Ortho-K regularly, along with the 2 or more modalities. But this is really, really interesting. I'm surprised by the lower percentage in Atropine as well. So great, very diverse group. Can you close that poll, please? Thank you. It just takes a sec to progress to the next slide after a poll. It doesn't want to progress.
Try clicking one more time.
Oh, here we go. Thank you. Okay, so moving along, let's talk about the examination. So obviously we want to do a detailed history. The genetics are important. Who in the family is myopic and what are the activities they're participating in? Obviously, we're going to do general and ocular health. When you start treating myopia, or myopia progression treatment, I should say, the refraction wet and dry is important. It's difficult. I mean, I've seen a lot of people say you should be doing wet rets every time or wet refractions. That's hard. I mean, we have limited time, but I definitely try to do one at least once a year, and at least on the initial one. This is important as well because we could be fitting contact lenses, we could be doing atropine, and in the future, really good myopia control glasses will be released. So an anterior segment evaluation is really important. Tear film as well, because I don't want to fit a patient in a contact lens and they have poor tear film, and that's unlikely with a child. But one thing that I have found several times, and particularly those patients with larger eyes, is lag ophthalmos. So if I have significant lag ophthalmos, it really makes me think about what modality I'm going to use. There are many of my colleagues do not hesitate fitting an Ortho-K lens on a lag ophthalmos patient. I tread very lightly there, or carefully, I should say there, because I have come across, and you'll see in one of my cases, I've come across issues in the past with lag ophthalmos patients, and even if we're adding ointments or gel, we know that compliance with kids is not great. Pupil size measurement. So when we are doing Ortho-K or multifocal or soft myopia control lenses, we want to make sure that that pupil's big enough to achieve that mid-peripheral blur. Okay. Also, if we're treating with atropine, we're going to be dilating that pupil slightly. So we want to see what the starting point is. So don't forget to do pupil size. Binocular vision. So I am not a binocular vision person for all of those people out here that know me. I'm definitely very much a contact lens myopia control person. But that being said, BV is very important in terms of our results, how we predict information. My previous partner is a guru, I think, in binocular vision. Her name's Angela Peddle. And we talked about this and about how accommodative excess, like XTs, XPs, can impact the progress or the changes in myopia. Okay, so it is important for us to take those initial tests, really to get their baseline and to see if their binocular vision status is influencing their myopia. Topography and horizontal visible iris diameter is important. Axial length, we touched on that already. And IOP, so remember we potentially are dilating the pupil a little bit, and so we want to take the pressures beforehand. Also, if you are doing Ortho-K, we can potentially change the corneal resistance, and that would change the effective IOP. So if you're measuring pre-Ortho-K and during the beginning of Ortho-K, you may get 2 different pressure measurements. Okay, so let's start with atropine. I titled this slide 0.01% because it is the main modality of atropine being used right now. Atropine therapy, as you know, has been used for more than a century. The ADAM2 study, though, really changed things, I think, for the entire world with respect to treating with atropine. What they did is they looked at 0.5%, 0.25%, and 0.01% atropine. And what happened was the higher dosages of atropine had more rebound. So meaning that after a couple of years, they stopped treatment and there was more rebound in the prescription. Whereas with 0.01% atropine, there was far less rebound. And the investigators decided that this was a more effective treatment. Now, several years have passed since the ADAM2 study, and we now see clinically that 0.01% may not be the be-all, end-all of atropine treatment. It is certainly a very good starting point, but we may have to modify the concentration based on what we're seeing clinically. And I'm going to outline a case on that as well. With 0.01% atropine, the effect on axial growth is unclear, and that is a real issue. I always think in the back of my head that if I'm applying atropine for a patient, my true goal is to lower the amount of axial growth, right? And if I'm not having a major impact on axial growth, then in my mind, I am still causing potential retinal thinning, increased chances of glaucoma, increased chances of all those pathologies that we saw in the beginning. So I have that always in the back of my mind, wondering, is this the best form of treatment, or should I be compounding it with another type of treatment? Okay, so research is needed in this area. I think there's a lot of unknowns when it comes to this type of treatment. Complications or I should even just say side effects of atropine. Blurred vision is the main one that I see. Light sensitivity, but not a lot. I mean, 0.01% really only dilates the pupil about 1 millimeter. So, side effects are not that common. I mean, exactly that common. But I wanted to list the major ones here as well, and these are more the adrenergic ones. I have never seen that clinically in terms of tachycardia, altered mental status, etc. Now, many of us here are doing soft myopia control lenses as well, and they are really straightforward to fit. I mean, I think that this introduction has really caused an explosion of myopia control treatment in this country. So they're typically center distance designs, and the stimulus for axial length growth is really hyperopic defocus. So, image behind the retina, whether it's central, whether it's peripheral. And what these lenses do is pull that peripheral image up in front of the retina and try to produce a stop signal. So it doesn't always stop the progression, but we are trying to stimulate that stop signal. So when I educate patients, when I'm actually treating them, I say the goal is to slow down and even potentially stop the progression of myopia, but that is not guaranteed because, as you know, for those of you who treat myopia, we see a huge gamut of results. So always guide parents' expectations. Traditionally, simultaneous design with a center distance is more effective because with a simultaneous design, you have multiple points of peripheral blur that can be used against pretty much the entire, or in front of the entire retina. It is very important that the add power is consistent. Okay, so you don't want any varying add powers that can cause a difference in the amount of myopia control. So I have some designs here. I had to make my own little designs because I couldn't use any company designs. So the first one I'm not sure if I can use the mouse here. The first one on the upper left is the concentric ring design. So we have a distant center, and then we have varying rings of distance and near, which scatter against in front of the retina, causing that peripheral myopic defocus. On the bottom left, we have aspheric. So for the longest time, I was treating with an aspheric distance design, and I got great results. In the particular design that I liked and I used, the optic zone, or I should say the central clear zone, was 1.7 millimeters. So that was enough to provide peripheral blur. Now, in a few weeks, we're going to have a new myopia control design in Canada, which is pretty exciting. And it works off of a pinhole effect. So in the bottom right corner, what I show here is the entire lens has a blur, and then you've got a central pinhole effect. And this design has done very well in the US. So hopefully we have equally good results here in Canada. And so what are some of the challenges I have with soft myopia control lenses? I'm not going to go through all of these, but the first few I think are the ones that we see more commonly. Blur distance is the #1 thing I see. So if, for example, the lens is shifted, if any of the ad passes through the visual axis, you're going to get a little bit of blur. I find children very tolerant to that blur. And so initially they may have it and they adapt over time. So don't be too quick to over minus those lenses. They can also get blur at near. Most of the lenses don't correct astigmatism. Luckily and coincidentally, today a new multifocal, well, it's not a myopia control, but a multifocal toric lens was launched today in Canada. So perfect timing. I'm pretty excited about that. So astigmatism may not be as big of a problem. They may not be able to tolerate higher ad powers. So if you're not using a myopia control design, but you're using a multifocal, you want to use a +250, at the very least a +2. And if they can't tolerate that, then you will not be able to use that particular lens. And you may need to over minus. So like I said, don't be too quick to over minus. The next three are actually just common contact lens issues like discomfort, dryness, a small risk of microbial keratitis, and typical soft lens complications. Finally, orthokeratology. Now, this, in terms of the way it decreases myopia progression, is similar to the soft multifocal because we are inducing myopic defocus, so peripheral blur. If you look at this particular picture, in the central area, we have this treatment zone, followed by the reverse zone, and you can have a relief zone with that as well. That helps with the curvature. There's the alignment zone, and then there's the peripheral curves. And the way that it works, so traditionally, people thought that Ortho-K actually pushed on the cornea and caused a reshaping of the actual cornea. We now know that that's not true. Okay, what is happening is that the tear lens that is underneath the Ortho-K lens has different gradient pressures. So the central area where the treatment zone is a positive pressure. If you go to the steeper reverse zone, there is negative pressure induced there. And what that does is change the shape of the epithelium. So centrally, we have flattening of the epithelium. Mid-peripherally, we have thickening of the epithelium. And that mid-peripheral thickening is what gives the myopic defocus or the peripheral blur. Okay. The complications associated with Ortho-K, I think, are more of an issue than any other myopia control modalities. And the reason is because so many people have this fear of microbial keratitis. And I'm going to go back to that in a second because I want to put that into context. The other issue with Ortho-K is discomfort. So discomfort's only in the beginning for the most part. I mean, kids have to adapt. They have their eyes closed. You know, it's something that they can adapt to very quickly. Corneal staining is possible. So like I said just a moment ago, you don't want bearing on the cornea at all. So corneal staining may mean that there's bearing on the cornea for some reason or another, and we have to fix that. Corneal edema. I have not seen corneal edema at all with Ortho-K when I am looking to the slit lamp. Of course, there's going to be some clinical changes, but it's microscopic. I have not seen it. Lens binding. So if any part of the lens is too tight, it can cause the lens to bind. Residual cylinder is possible, and decentration of the lens is also something that's commonly seen with Ortho-K. So back to microbial keratitis. Mark Bullimore researched, did a retrospective analysis of microbial keratitis rates between adults and children in with Ortho-K patients. And he found that the incidence of microbial keratitis was similar in Ortho-K patients to other overnight modalities. So it's not worse, it's similar. And in fact, some have said that it may even be less than other overnight modalities, because with other, other extended wear modalities, they are using the same lens for a month, a week, 2 weeks, whatever it may be at a time, and they have the potential to become dirtier, right? These lenses are being cleaned every day. So there's this massive fear that goes on, with our ophthalmology colleagues, with certain patients, what they read on the internet, and we have to put it all into context. Okay, and that's what I try to do with patients. I use actual percentages, stating that you may read this on the internet. There is a chance of microbial keratitis. If your child ever has a red eye, light sensitivity, I want to see him or her right away, but the chance of getting it is very low. Okay, so that's an important conversation to have with the parents, so they don't read up on something that we have not educated them on. When it comes to decentration of Ortho-K lenses, I think back to school. Many of us don't fit, I fit RGPs regularly, but many of us don't anymore. And when you think back to RGP training, when a lens is decentered superiorly, what does that mean? So potentially it means it's too flat. In the world of orthokeratology, we don't really talk steep and base curve, flat and base curve. We talk increased sagittal depth, decreased sagittal depth. So if this particular pattern is called a smiley pattern or a smiley face, the lens is decentered superiorly, we want it to drop. So we increase the sagittal depth. And the increase of the sagittal depth can be done through basically steepening any of the curves in an Ortho-K lens. Okay. Conversely, when a lens drops, and this slide was given to me by Randy Kajima, who is a great Ortho-K fitter, when it drops, essentially what that means is there's too much sagittal depth, and we want that lens to rise up so we could flatten any of the curves. I mean, a lot of the time we're changing the overall diameter or the alignment curves. Those are easier to do. But essentially, if you were doing this yourself, you could change any of them. And I'm trying to, really make this basic. If a lens is laterally decentered, it could mean it's too flat, it's too steep. And another issue I think that is really important when it decenters is think about the asymmetric cornea or even the toric cornea. Do we need to put toric peripheral curves onto that lens? Okay. And another issue is if the lens is too small. Okay? If the lens is too small, make it bigger. It will help center it better. Okay, so before I move into the cases, I just want to give you a summary. This is based on some newer data, because a lot of us have seen summaries on how effective all of these different myopia control modalities are. And so this one, Cooper and his group published this, and the range between a meta-analysis. So the meta-analysis is the first column where they looked at just prospective studies, and then Cooper's group looked at retrospective and prospective studies. And the range is as follows. So atropine at high dosages, the effectivity is 65 to 85%. Moderate dose is 65 to 76%. Low dose, so for example, 0.01% atropine, 45 to 60%. So this is actually lower than what we were told a few years ago. Okay, Ortho-K is 45%, multifocal 33 to 40. Progressive lens and bifocals, look how low this is, so 12 to 16%. There is massive opportunity in that space. It's just that we haven't seen any great designs. And just as a side note, sometime this summer in Canada, there is going to be a newer myopia control glasses lens launched that have had excellent results overseas. If you want to know more about it, I can talk to you after the presentation, meaning you can email me and I can tell you what the design is, but I'm not allowed to give that information during this presentation. Single vision, 0, and then under correction, as we know, contributes to myopia progression. Okay, and then in terms of the challenges in office, I mean, we have to make sure that everybody in the family is on board. The children have to be on board, parents are on board. This is not something that we should be forcing anybody into, okay? The kids have to be part of this conversation. If a child starts any of these types of treatments and stops suddenly, there can be a rebound, okay? So parents, I always make sure parents understand that. There's situations where, you know, say you have a 5 or 6 year old and you don't want to put them in contact lenses. Atropine is a logical choice, but what if they don't want their kids on drops? I mean, I don't blame them. They're not like, I wouldn't want my child on medication for the next 10 to 15 years. It's a tough call, and they really need to be educated in that particular situation. Astigmatism. So depending on how much astigmatism the patient has, it can affect our contact lens fit. In those situations, we may be thinking more along the lines of atropine or adding glasses on top of the contact lens fit. Higher prescriptions are always tricky. I mentioned leg ophthalmos already, and obviously finances. I mean, this often isn't covered by private insurance and certainly not by OHIP. Okay, so let's get into the cases. Okay, so case number 1, a 3-year-old Asian boy, patient AT, presents for an eye examination. Both parents are myopic and have had LASIK. The patient was 20/20 with Leia symbols, and the dry ret was plus 1/4 OU. Wet ret was plus 0.75 OU. Parents were educated on the high risk of myopia, so he was a low hyperope at a very young age. And the mother admitted that he spent very little time outside, which is another risk factor. I usually see these types of patients every 3 to 6 months. Unfortunately, even though I educated the parents, they came back 2 years later when the child was 5 years old. And this is what the prescription was. So his dry was -2 with some sil and -150. The wet was 1/4 down from that. So a 2 diopter jump in 2 years. Everything else was normal. So polling question number 2. Now, if this was your patient, what method would you recommend? So A, would you use myopia control glasses? B, would you use atropine 0.01% and a distance RX? C, soft multifocal lenses? D, would you put them in Ortho-K? E, using atropine and myopia control lenses? Let's give you a little bit of time to do this. So again, there's no wrong answer to this, and there's no right answer. This is something that I want to see just what people's preferences are. So let's see the polling results. So quite a range. That's great, actually. So about 29% of people thought myopia control glasses are better. And that's really interesting because, again, it shows where our comfort levels are around atropine. 22% at atropine with a distance RX. Highest amount was atropine with myopia control glasses, and that would also be my preference as well, but that's not what ended up happening. Can you close the polling results? And it might take, let's see if this advances quickly. So I'm going to talk through, it's not advancing, but I'm just going to tell you what I did at the time. Try again?
Click again. Yeah.
Okay. Still not going.
Try again.
It doesn't want to leave this slide.
Can you move your mouse?
Yep.
Okay, maybe click on the slide and see if that works.
Oh, there we go. My mouse got in the way. Okay, so I put the patient on 0.01% atropine. I talked about myopia control glasses. Mother decided not to get them, and she ended up getting the distance RX. So 3 months passed. So I usually check these patients every 3 months, and what a huge jump He went from, so the right eye didn't change at all. The left eye went from -150 to -225, even with the atropine. Now remember, he's young. He's now at this point about 5 or 6 years old. This is very aggressive. So we needed to do something more. Okay, so this takes me to polling question number 3. So if this was your patient, what would you do at this point? Would you add the myopia control glasses now and insist with the mother that that's what you need to do? Would you increase the concentration of atropine? That's B. C, increase the concentration of atropine and use myopia control glasses. D, switch to contact lenses, meaning ortho-K or soft lenses. Or would you just leave him the way it is? Because there's a possibility he may just, the two eyes may have been equalizing, and there's no need to make changes at this point. Again, no wrong answer. So 40% added myopia control glasses. Very interesting, okay. And then 7% went up to 0.02% atropine, 34%, so almost the same amount of people put down, increase the concentration of atropine and do myopia control glasses. And I agree with that as well. Can you close the polling results? And let's, if I get rid of my mouse, see if we can advance this time. There we go. Okay. So again, I tried to push the myopia control glasses as well, but again, the mother was just like, let's increase the atropine. She's very strong-minded, so it's very difficult for her to take my recommendations completely, unfortunately. But we did bump up the atropine. I did educate because I have had patients in the past who have had accommodative issues and light sensitivity with 0.02% atropine. Fortunately, at the 3-month follow-up, there was no change, and he was doing well. I mean, there was no issues with light sensitivity. However, at 6 months, pupils appeared dilated during his eye exam with me. So I did check the pupils, and they were dilated. He found that I checked his near vision, actually, there was a slight reduction. So I believe that he went from 20/20 to 20/25 or 20/25 minus. And the mother said he'd been complaining lately about light sensitivity. So this was something, you know, that I'm not completely comfortable with. However, there are many people who are comfortable with that, because I forgot to mention, every time I do atropine therapy, I add sunglasses. So I say whenever they're outside, I want, you know, either progressives or sunglasses. Now, this takes me to pull. Now, this question is very similar to the other ones, but I'm just curious what everyone wants to do next. So we now know that he's got issues with accommodation. His pupils are dilated slightly. What are you going to do? Are we going to, again, add myopia control glasses? Are we going to reduce the concentration of atropine? B. C, reduce the atropine and go back to myopia control glasses. D, switch to contact lenses, or make no changes. What do you think we should do? Okay, so the vast majority of people want to decrease to 0.01% atropine, and that's what I did as well. I wasn't comfortable with this, and it's interesting. Can you close the polling results? So it's interesting because I spoke to some experts in the States about this patient as well, and here, let me try to. And there are many people that are completely comfortable with keeping the pupil dilated and having those results. I still haven't wrapped my head around it fully. I feel like if a child is 5 to 7 years old and we are dilating that pupil, what is the potential repercussions of that? You know, are we going to keep them on atropine until they're 18 years old? It is a possibility that we are. And I don't know if I'm comfortable with that type of exposure. So I had another conversation with the mom, and I think part of her hesitation with myopia control glasses before was really the poor effectivity associated with them. I mentioned this new type of design that's going to be coming out. So I saw her recently because what ended up happening was he went back to 0.01% atropine. I had talked again about the glasses. I saw him after the pandemic, like reopening of practice, which was just a couple of weeks ago, and he had advanced another 3/4 of a diopter. So the 0.01% did not work well for him. Maybe the combination of this new design will, but the mother, I had been talking to the mom about Ortho-K and other modalities for quite some time. And finally, you know, because she was so young, she was hesitant. Finally, she is open to trying other things. She really, I was having a hard time convincing her. But when she saw her child go up to a -3, even with treatment, she, I think, is more on board with trying other modalities. So it's really interesting. I shared this case with you because this is probably one of my atropine cases which was not straightforward. Myopia control treatment is very, very successful, and I've had fantastic results. But again, I wanted to show you what potentially could happen. So the take home on this is we need to think beyond 0.01% atropine. It may not be enough for some of these more aggressive cases. I didn't mention seasonality before. So seasonal changes can occur, and think about it. I reduced the 0.01% in November, and I just saw him when I reopened, so June. So through the winter, myopia tends to increase more rapidly. And always, you know, this is not one of those things. Myopia control is not something we just treat and we're done. This is something that we have to continue to work with the patient on. The next case I have is a 12-year-old Caucasian female referred to my office for myopia control. She was changing 0.75 a year. She was around a -5. If you look at these topographies, her corneas are pretty steep. They're about 47 in the right, 47.7 by 46 in the left. So, you know, pretty steep. I wanted to make sure that there was no possibility of keratoconus developing. So I sent her for a pentacam. Pentacams look fantastic. When you look at the central corneal thickness, even the peripheral corneal thickness, it's great. If you look at the bottom right corner of the pentacam, there are no islands on the elevation map. And if you were looking at the upper right pentacam, that's the front elevation. When we are designing Ortho-K lenses, and if we're thinking about a toric lens, we want to look at the elevation differences between the vertical and horizontal meridians in the periphery. And this particular patient would have done great in a toric lens, but at the time when I fit her, we didn't have access in that high of a prescription. So I had to fit her in an Ortho-K spherical lens. Okay, and these were the parameters. So initially, even for the first year, the lens was really well centered. She was plano. She did very, very well. So we had regular follow-ups in the first year. But the problem is then I didn't see her for a full another year. And this is what happened, like full superior nasal decentration OU. And if you look at the refractive error, there's some induced astigmatism and hyperopia. She, on the other hand, was perfectly happy. So this will happen sometimes with these Ortho-K patients that are, you know, very happy. You'll look at their topography and say, oh my gosh, what happened there? Why are they so happy? Well, you know, she's a -5 and she's seeing pretty well. But this is not an acceptable fit. So what I did is I was concerned because now she's been in the lenses for 2 years. I decided to wash her out of the lenses and reorder the lenses in case those lenses had become warped over time. And at first couple days, or even first couple weeks, they were well centered and then they decentered again. So then we know that this lens is not fitting on that cornea anymore. And for those of you who do fit Ortho-K or plan to fit Ortho-K, the washout time of a few weeks is not enough. The problem is that with Ortho-K, you don't want to do a washout of months because you risk of rebound. You know, so in this case, I made changes to this lens. And what I particularly, actually, you know what, I'm going to ask you. So this is polling question number 5. What would you do in this situation? Would you increase the diameter of the lens? Would you use toric peripheral curves? Would you increase the width of the alignment curve? Or would you do all of the above? We need music in the background. Okay. So none of these were wrong. We could do any of them, right? So, and that's, I actually did do all of them in when I changed the lens. So can we close this? Okay, so basically she was fit with a wider alignment zone. I went to a larger diameter and I put in toric PCs. The problem is that when you have a -5, when you're treating a -5, it is a lot harder to fit than a -3. The higher power that we have, any kind of misalignment in the cornea causes decentration very, very easily. And I could not get this lens to recenter. If she was a -2 or a -3, it would have been much, much easier. So what I decided to do is switch her over to a soft myopia control lens. And it worked very, very well. She has not progressed at all with respect to Ortho-K or the soft myopia control lens. So this is an example of a patient that you could switch from Ortho-K to a soft lens without any rebound. Okay, so my next case, we're getting close to the end of the hour, so hopefully I can get through 2 more cases. This particular patient, I'm not going to go through all the BV stuff. She was referred for a BV workup with my partner, Dr. Petal. You can see that she's got some significant astigmatism and myopia. She actually went through vision therapy first before seeing me. And through vision therapy, she was able to, she had accommodated in facility, virgins in facilities, she had some visual perceptual issues, and she was able to treat all of that within 20 sessions. During that period of time, her myopia did continue to increase. Now, she's, like I said, she's got some significant SIL. And her dad, we didn't know this earlier, but when I was talking to her about the parents, dad's a -16. So they are acutely aware of how high myopia can go. And they wanted to try anything. And they specifically asked for Ortho-K. So traditionally, I don't fit a -3 SIL with Ortho-K, or if I do, I educate them that they will need glasses or a soft lens on top of that. And they were completely on board. Here is her topography. So beautiful pattern. At the time when I started fitting her, there was also not toric peripheral curves. So I was a little concerned with decentration, but look at that topography, it was great. The only issue I saw with those lenses is very, very mild staining inferiorly at, whenever I did my morning appointments, but I didn't think anything of it. I thought it was just a little bit of the edge, and it was so mild, I wasn't concerned. So the patient wore glasses on top for some time. 2 years into wearing the lens, parents call and she has a red eye, light sensitivity. And I thought, oh God, here's my first microbial keratitis. So patient came in and she had developed inferior corneal infiltrates. It was inferior, it was sterile, it was not infectious, thankfully. But that is the first time her parents told me that she sleeps with her eyes open. So she had leg ophthalmos. And as I told you earlier, I am not a big fan of doing Ortho-K on leg ophthalmos patients. So with this particular patient, I added gel, of course, but I want to know from you what else you think we should be doing. So I treated the infiltrates, I added ointment, but should we just stop Ortho-K and put her in glasses. B, we treat her and then try Ortho-K again. C, refit her into soft multifocals. Or D, try Atropine. So again, I mean, this is a clinical choice, but I also made my decision based on the parents' needs and wants as well. Okay, let's see what we got. So 48% put her into soft multifocals. So that, so we'll see where we could progress to this. So very interesting. So quite a range in what people were doing there. So I'm going to, I can't minimize my face. There we go. Okay, now what I decided to do with the parents is very, very cautiously, I tried Ortho-K again, and I literally followed her day 1, day 3, just to see, is this going to return? Is this a result of her lag ophthalmos? And within 3 days, the infiltrates were back. And I told the parents, we're out. There's no way we're doing Ortho-K anymore. Parents were absolutely opposed to Atropine, and that left us with soft multifocals at the time. Now, remember, she's got a ton of SIL. I put her into I put here center near, I meant center distance, sorry about that. It's center distance, a toric multifocal in a plus 250 ad. Her vision was terrible, it was 20/40. And so I had to bring her down to a plus 2. So with the plus 2, she was able to see 20/25 in each eye. Within a couple of months, I don't even think it was 3 months, her myopia rebounded by 3/4 of a diopter. I was absolutely mortified. I was so upset because she had done well for so many years. I added a progressive. Parents were still completely against Atropine. A few months later, she rebounded another 3/4 of a diopter. So it's obvious to me that this soft lens was not working well on her at all. And what should we do next? I mean, this was something that I really had to sit down with the parents and say, we can't, I'm not comfortable with her myopia rebounding at this rate. The parents said to me, is there any way you could go back and Ortho-K lenses? And, it took me time to really sit and think, like, is this something I'm willing to try again? But the difference is that torics were available now. And I thought, well, maybe there was an issue because that lens was not toric. I mean, along with, of course, the lag ophthalmos. It was risky, but we were both committed to checking her frequently, and so we tried it. Look at that beautiful fit. She has now been in this modality for another 2 to 3 years, no infiltrates. So, I mean, I'm sure many people listening to this would think that is very risky. I think it's risky myself, but it worked really well, and I am very conservative with checking these patients. She does wear daily disposable toric lenses during the day, and she's doing great. She's very, very happy. I just want to see, I think, do we have time for one more case, or should we end now?
You can do one more case, that's fine.
Okay, so case number 4, this is an interesting patient too. So she also was referred for binocular vision, but we did myopia control therapy at the same time. She also, actually, I'm going to skip this case. I'm going to go to my next one, which is actually, because I don't want to do another Ortho-K one. Go to case number 5. Okay, this particular patient started off in her referral being almost plano. She was also referred for vision therapy. And vision therapy went on for a couple of years. And during that period of time, her progression in myopia went up from pretty much plano to -3. Dr. Polanenko was the optometrist who was seeing her at the time and said to the parents, you really need to do myopia control therapy. And the parents just weren't listening. Finally, at a -3, they presented to my associate actually, and my associate fit the patient in a daily disposable myopia control lens, okay? And what ended up happening, actually, I'll go back for a second. What ended up happening is she was seeing great for distance, terribly for near. And immediately after she got home, she said, I can't read anything. Well, the issue was that when she went from like plano to a -3, she was only wearing her glasses for distance. So that means she was not using any of her accommodation for near. Okay, so with these myopia, the myopia control design lens, it is not a multifocal. Even though there's a +2 add in it, the purpose is not to provide the add for reading. So she was essentially, the way that it's designed, she was essentially looking through a distance lens without any trained ability to accommodate well. And so what we ended up doing is refitting her into a multifocal distance center design, and immediately she could read. Okay. So she was very, very happy with this particular design. The reason I brought this case up is this is going to happen. It's happened to me several times where I've put patients in a myopia control design and had to switch to a center near multifocal design. So keep that as part of your armamentarium because it's something that you will need to use. Her myopia has not increased at all in the past couple of years that she has been in this design. So we're really, really pleased. So I want to skip to, I have one more case, but we're running out of time. So I'm going to go all the way to the end. To conclude, I mean, myopia control is really the future of really controlling these patients. They are the epidemic is growing. With 50% in the future, optometry has the ability to really own this. And where the future is with myopia control is using it synergistically, meaning using one modality, Atropine, with soft multifocals, or Atropine with Orthokeratology. We need to learn how to discontinue wear better, okay? How to stop, take these patients out of their contact lenses. And continued research is huge, and there is lots of funding going towards this. But remember, when you embark on this, it is not without complications. I have chosen for this presentation really the bulk of my complicated ones because I see about 3 to 4 myopia control patients a day, and a lot of them go very seamlessly, but we need to know how to manage these complications. If you want any references for yourself or for patients, here's some websites. I think they're great for patient references. Again, we have the ability to decrease the amount of myopia worldwide. And that is a huge impact that we potentially have. I am open to questions, definitely. This is me in my new world. And I haven't, we're not allowed to do contact lens fits, but so this is me pretending to train on one of my staff members. I have my email there below. Please contact me if you have any questions after the question and answer period right now. Thank you for your time.
Thank you, Dr. Thakrar. So I will now share the questions you've submitted. The first question, is there any concern about an iron deposit line for Ortho-K?
So I'm not really, so an iron deposit line really is iron depositing in a steeper area of the epithelium, or like a slope in the epithelium. So even with keratoconus, when you see an iron line, it's usually at the base of the cone. So I'm not concerned at all about iron deposition. It's really, it comes from the tears and it just literally deposits against that curve. So it's not something that should be deterring us in any way.
Okay, thank you. Another question, where do you source your Atropine 0.01%?
So great question. We use compounding pharmacies. So I try to find a compounding pharmacy near where the patient lives. And be careful about that too. I'm getting a lot of variation lately. I like to have a non-preserved base to the Atropine. So, lately we've had preserved solutions with patients' Atropine, and that is something that's very important. If a child is going to be on this for many years, I want that base of dilution for the Atropine to be non-preserved. Okay, so they should be refrigerating their Atropine and maximum having it for a month at a time. Okay, but any compounding pharmacy, almost any compounding pharmacy will make it.
Great, thank you. Another
You're welcome.
question, and this is a two-parter. When you're discussing myopia control options with patients and parents, do you recommend all options and let them decide, or do you tell them what you think would be best for them? So that's the first part.
Mhm.
And then I find parents have a lot of questions when bringing this up for the first time and don't typically have time to get into a detail during the 404. How do you present it to families and answer their questions?
So it's impossible to do all of it during the 404. So what I often do, so a lot of my myopia control patients are referred to my office, and then some of them are already kids within the office. What I find really effective is booking a myopia control visit, which I take about half an hour. I charge them for it, but that charge goes towards the treatment. And that gives me ample time to go over everything. So I give them all of the potential options, and at the end of all of the potential options, I tell them what I recommend based on their eyes, their prescription, their age. I also give them handouts. So during that myopia control visit, there is so much information being given to them that there is no way that they can retain all of that. So it's best to give them written information.
Great, thank you. Another question, do you cyclo all pediatric patients every year or just the myopia risk ones? And do you do this at their 404 or have them come back?
I don't cycloplegia them every year. The low hyperopes, I don't. With the myopes, I do, because I want to be consistent in my measurements. If I'll be honest with you, there's times where I haven't had time. Like you can't, it's really difficult at times to do everything. You may have to have them back for the cycloplege, but if you are really, truly tracking their myopia, we do need to be doing cyclopleges on these particular patients. But again, I don't do it on every single patient or every single child.
Great. We have another question. What's the difference between a myopia control lens and a center distance multifocal?
So it's really branding and how they've designed it. So, in Canada, there are, and there's going to be a new one. So there we have approval for quote unquote myopia control lens. So your traditional multifocals that you can think of, the distance center, which I can't name the brand names, sought approval as a multifocal. Those other ones sought approval as a myopia control. And it's a lot of its marketing, a lot of its nomenclature, but it's difficult to it's difficult to explain this without going into brands. Um, the lens that I am thinking of, it is not your traditional multifocal because patients cannot read up close with it, but it does have attributes of a multifocal. But the company will be very quick to say that it is a myopia control lens, not an ad. If you want, email me if you want more specifics on that. I can be much more detailed if I'm talking brands.
Thank you.
Sorry, it's
Yeah, it's
tough.
hard. It's hard in a cope lecture. The next person has asked you to go back one slide. They want to see the parent resource websites again.
Sure, of course.
And while that person's looking at those websites, we have another question. How do you decide between a myopia control lens and center distance MF? Are there any daily disposable center distance MF lenses available?
I'm sorry, can you repeat the question? I missed part of
Yeah.
it.
How do you decide between a myopia control lens and center distance MF? Are there any daily disposable center distance MF lenses available?
So the short answer is no, not yet. I right now am really gearing more towards the daily disposables because it's children, it's easy. We're all gearing towards daily disposables with even single vision lenses. So I go there first. Even this new one that's going to be launched in a couple of weeks, it's a daily disposable. I now use the the reusable ones as a problem solving if the daily disposable doesn't work.
Okay, thank you. We have two more questions. Will myopia control be effective using Ortho-K when pupils are small?
Not really. So typically the treatment zone is 5 to 6 millimeters, usually smaller and higher prescriptions. If the pupil size is smaller than that, then you should not be using Ortho-K, or talk to your lab about reducing the treatment size, but it won't work well. It won't center properly. So in that situation, I would move on to a different modality.
Okay, and our last question, is there any information about what time is best to instill the atropine drops, morning, night?
That's a really good question. I have a stack of papers on atropine, and I have not seen that. If someone knows that information, I would love for you to email me, but I know it. I don't think that that information is out there.
Okay, at this time, I'd like to thank you, Dr. Thakrar, for your insightful presentation.